Good evening. We'll continue with our NEET PG 2024 questions. So it's a big question. We'll read from the last line. What is the probable diagnosis? So try to pick up clues leading to the diagnosis from this big question. A 56 years old male presents with breathing difficulty for 2 months. He also had cough and mucopurulent expectoration for the past 6 months. He has lost 12 kg in the past 6 months. He denies any significant history of fever. X-ray chest showed a right-sided pleural effusion. Rest of the clinical examination and basic blood workup was normal. The pulmonologist performs a USG-guided pleural fluid aspiration. The reports are as follows. So even though it's a big question, the gist is simple. We have to interpret this pleural fluid analysis. Okay. So we will remember the Light's criteria. Okay, so we'll finish the question first. The pleural fluid protein was 4, the serum protein was 7. So the first part of the Light's criteria is pleural fluid protein divided by serum protein has to be more than 0.5 if it is an exudate. So let us divide. Pleural fluid protein in this case is 4, serum protein is 7. So definitely it is more than 0.5. Okay. So the first criteria holds towards exudate. What is the second criteria? Pleural fluid LDH divided by serum LDH is more than 0.6. So our pleural fluid LDH is 230 and our serum LDH is 300. So this also comes around 0.7 or 70%. Rough calculations are enough. So the second criteria also holds good. If pleural fluid LDH by serum LDH is more than 0.6, it also points towards exudate. What is the third Light's criteria? The pleural fluid LDH is more than 2/3 of the upper limit of LDH. So usually the upper limit of LDH is taken as 300. So more than 2/3 of 200 is 300 is 200. So in short, if pleural fluid LDH is more than 200, it points towards exudate. This also holds good in this case, right? It is 230. So if 2 out of these 3 criteria is positive, then it is exudate. If one or none of the criteria is present, then it is a transudate. So once you have differentiated whether it is transudate or exudate, finding the cause is important because transudate is always due to a systemic cause. Any systemic condition causing fluid overload like heart failure, renal failure, liver failure, hypoalbuminemia, etc. will cause transudate. All local causes will cause exudate. There are actually more than 20 causes of exudate if you take it individually, but in short, any local cause, think maybe it could be a pneumonia. The pleural effusion in pneumonia is called as parapneumonic effusion. Tuberculosis is also an infection. It could be pulmonary infarct of pulmonary embolism. It could be malignancy. Anything, any local cause. Maybe one question which they can ask in NEET is, what about autoimmune diseases? For example, in rheumatoid arthritis, there can be bilateral exudatic effusion. Okay. The word bilateral exudate is important because even if you forget this Light's criteria, based on the clinical clues, you can make a diagnosis. For example, you can see in this case, see the clue is very clear. He has cough, mucopurulent expectoration, there is weight loss, it's a long-standing process, and the effusion is only one-sided. So mostly this has to be a local cause. And in India, any cough lasting more than 2 weeks always has to be ruled out for tuberculosis. So the answer here is tuberculosis. See the other three options, CKD, CLD and heart failure, these are systemic conditions. So even if you get confused or if you get tensed by seeing the big question here, the answer is pretty easy to crack. Okay, so transudates are usually bilateral, exudates are usually unilateral, except in rheumatoid arthritis where we get bilateral exudatic effusion. Okay, so this is about Light's criteria and assessing pleural effusion. So coming to question number 29, this is a very short question. What is the role of interleukin 8 in ARDS? So whether it is neutrophil chemotaxis, endothelial activation, macrophage activation or eosinophil activation. This has to be a one-liner. You have to remember it as neutrophil chemotaxis. So this question can come in medicine as well as it can come in microbiology also. I think you would have remembered in microbiology there's a table which you have to remember. The various interleukins activated by which cells, what are its functions. Remember, interleukin 8 is for neutrophil chemotaxis and neutrophil activation. There are many interleukins. Try to remember every one of them if you can. Eosinophils, remember it is interleukin 5. Okay. Right. Since this question is about ARDS, I'll just discuss in short about ARDS, acute respiratory distress syndrome. Though this is a straightforward question, another question had come in 2024 from ARDS. It was like a clinical scenario. So what is the Berlin's criteria in ARDS state? 1. So we should have breathing difficulty within 1 week of a particular clinical insult. So this is a clinical criteria. The second criteria is imaging criteria. There should be bilateral lung opacities in X-ray, which is not explained by any other clinical diagnosis. This is an X-ray finding. Third one, we have a ABG finding or a PF ratio. That is PaO2 FiO2 ratio. PaO2 is the arterial partial pressure of oxygen of the particular patient, and FiO2 is the fraction of inspired oxygen. Remember, when we breathe room air, the FiO2 is 0.21 or 21%. So the normal ratio has to be more than 300. So if the ratio is more than 300, it is normal. 200 to 300, it is mild ARDS. 100 to 200, it is moderate ARDS. And less than 100, it is severe ARDS. So one clinical criteria, that is patient should have shortness of breath within 1 week of a particular clinical insult. So what is that clinical insult? It could be anything, which means anything which can directly affect the lung also can cause ARDS. For example, a patient is having a pneumonia, it can worsen to ARDS. It's a direct lung disease. It can activate neutrophils or it can cause an inflammatory reaction and involve the entire, both the lungs. Or we can have drowning. Drowning is also something related to lung damage. Or we can have any aspiration pneumonitis like kerosene aspiration, etc. So these are lung diseases. When a particular damage occurs in one lung, it triggers an inflammatory reaction. Many cytokines get released. They damage both the lungs, causing ARDS. The clinical insult can also be non-pulmonary. So this category forms most of the scenarios. For example, assume this scenario. A patient was given a blood transfusion. So within 6 hours, he develops a breathing difficulty. X-ray is taken, it shows opacity. PF ratio shows reduced PF ratio. So what is this? It is TRALI, transfusion reaction associated lung injury. So it occurs in the background of a transfusion. It is not a direct lung condition, but on transfusing, the donor cells have some interleukins or have some cytokines which cause this lung injury. So another one is burns. So you can have burns, pancreatitis. These are some surgical conditions which lead to systemic inflammatory response syndrome, which damages the lung and lead to ARDS. So remember, ARDS is also a part of the systemic inflammatory response syndrome. Any condition like a sepsis, infection, trolley burns, pancreatitis, trauma, anything can, which leads to SIRS, can also damage the lung. Lung damage is called ARDS, that's all. Okay, so this is about the ARDS criteria and some possible clinical scenarios which can come. I also compiled another small table. Maybe it may be useful in some places. I didn't compile every TNF alpha. I just want to mention a few medical aspects of TNF alpha. For example, we know very well about TNF alpha and interleukin 1. They are the major pro-inflammatory cytokines. Maybe in last minute, if you are confused about the terms inflammation and immunity, immunity is of two types, right? Non-specific immunity and specific immunity. Inflammation is one part of non-specific immunity. The natural defense systems, the neutrophils, macrophages, dendritic cells, all these have a non-specific immune response. Whatever agent, whatever damage comes to the body, these cells fight against that. And when these cells, the neutrophils, macrophages or dendritic cells get activated, they release some cytokines. Those cytokines stimulate either T cells or B cells. That is T lymphocytes or B lymphocytes. These are called specific immunity because when T cell gets activated, they get transformed into few cells like Th1 cells, Th2 cells, etc. And they go on to mediate cell-mediated immunity. So T cell immunity is cell-mediated immunity. What do B cells do? They go on to produce something called as humoral immunity. That is, these B cells finally become plasma cells. Plasma cells secrete immunoglobulins. We have 5 immunoglobulins, right? IgG, IgA, IgM, IgG, IgE and IgD gamed. So these 5 immunoglobulins are secreted by the B cells and they mediate humoral immunity. So TNF alpha, interleukin 1, interleukin 6, these are some cytokines which mediate inflammation. They mediate non-specific immune response. Whereas coming here, interleukin 2, interleukin 4, interleukin 5, etc., they mediate specific immunity. For example, interleukin 2, interleukin 12, interleukin 17, 23, etc., these are cytokines which are needed for T cell activation or they are needed for cell-mediated immunity. So when you are reading some diseases will be dealt by cell-mediated immunity. Some diseases will be dealt by humoral immunity. For example, in dermatology, psoriasis or psoriatic arthritis is a disease which is mediated by, or the disease pathology is mediated by cell-mediated immunity. So which are the cytokines will be more in psoriasis or psoriatic arthritis? Interleukin 2, interleukin 12, 17 and 23. So we have to give drugs which act against these cytokines. Whereas consider some other diseases like rheumatoid arthritis or bronchial asthma or like allergic conditions. Their pathogenesis is mainly mediated not by cell-mediated immunity but by humoral immunity. So corresponding antidotes will help. So if you read more about the mechanisms, or you can correlate somewhere. Some MCQs may help. So TNF alpha, TNF interleukin 1, interleukin 6 are non-specific, or they are a part of inflammation or innate immunity or non-specific immunity. Interleukin 4, interleukin 5, I told they are part of the humoral immunity. See 17, interleukin 23, they are part of the cell-mediated immunity. I mentioned some diseases also. Psoriasis is a disease mediated by cell-mediated immunity. Allergic conditions like urticaria, eczema, asthma, they are mediated by humoral immunity. Rheumatoid arthritis, this familial Mediterranean fever, gout, Crohn's disease, they are more inflammatory component. Okay. So TNF alpha inhibitors, example etanercept, infliximab, adalimumab, they are used in these diseases. Interleukin 1 mediates fever and inflammation. So antidote is anakinra and canakinumab. See the diseases where it comes, familial Mediterranean fever and gout. So this can be one important question. Remember, interleukin 4 antagonist is dupilumab. They are used in allergic conditions like chronic urticaria, asthma, mast cell diseases, etc. Interleukin 5, remember, they are activate against eosinophil. Interleukin 4 activates IgE. So we have benralizumab, mepolizumab, they are used in asthma. You would have heard about another monoclonal antibody in asthma, which is omalizumab. Omalizumab is a monoclonal antibody against IgE. Remember, IgE and eosinophils come together in asthma. So omalizumab is anti-IgE, benralizumab and mepolizumab are anti-interleukin 5. If you want more specifically, benralizumab acts against interleukin 5 receptor. Mepolizumab acts against interleukin 5 itself. So omalizumab, benralizumab, mepolizumab, these three are monoclonal antibodies used in asthma. They specifically act on IgE or interleukin 5. For interleukin 6, always remember tocilizumab. You would have remembered in COVID-19. Interleukin 17 antidote is secukinumab, and interleukin 12 and 23 antagonist are ustekinumab. Both are used in psoriasis. So just for a screenshot use. Okay. So continuing to question 30 of previous NEET PG. So a 24 years female patient gets admitted with drowsiness and irritability. Evaluation showed a calcium level of 14 milligrams per deciliter. Which of the following is more likely to be a cause of condition? So this is also a pretty straightforward question. We know that the normal serum calcium level is 9 to 11 milligrams per deciliter. If possible, try to remember the other units also, like the millimoles value, milliequivalence value. But for more clinical use, at least remember this one. The normal serum calcium level is 9 to 11 milligrams per deciliter. Less than 9 milligrams per deciliter is hypocalcemia. Hypocalcemia is also very important because some conditions like vitamin D deficiency, okay, rickets. So all this will have hypocalcemia. Remember, one important hormone which mediates calcium balance is parathyroid hormone. Calcium metabolism itself is very important because it's not only parathyroid hormone which mediates calcium balance. We have few other things like vitamin D, parathyroid hormone, and we have calcitonin. All these hormones, vitamin D is also considered a hormone. All these have a role in calcium balance. Calcium is taken from diet. Okay. Calcium is stored in bones. So in which all places we can mediate calcium balances? One is from the gut. Because we need some mechanisms to absorb calcium from the gut. Another place where calcium metabolism happens is in the kidney. We have some mechanisms to reabsorb excess calcium from the kidney. Calcium is reabsorbed from the distal convoluted tubule. Phosphate is reabsorbed from the proximal convoluted tubule. That is also a basic MCQ. And all the absorbed calcium is deposited in bone. But bone is not a static organ, it is a dynamic organ because whenever needed, the calcium is absorbed from the bone and is taken into the blood. And whenever in need, excess calcium from the blood is deposited in bone. So bone is basically a dynamic organ of calcium balance. So what does parathyroid hormone do? Parathyroid hormone, it increases calcium in blood. How all calcium can increase in blood? It increases absorption of calcium from the GIT. Hence, blood level of calcium increases. In kidney, how can it increase calcium? By increasing reabsorption of calcium from the distal convoluted tubule. From the distal convoluted tubule of kidney. And how does it increase calcium from the bone? It increases bone resorption. So whenever parathyroid hormone levels increase in the body, the bone gets eroded of its calcium and everything will increase the blood level. So increased blood level of calcium, that is called as hypercalcemia. Okay, so for hypercalcemia, parathyroid hormone has to be in excess. The opposite happens when parathyroid hormone is low. Blood calcium will be low, that is called as hypocalcemia. We have another question on that, so we'll discuss it again sometime. How does vitamin D help? Vitamin D is very simple. It is more friendly in the bone, right? That is, it increases calcium from the GIT. In fact, parathyroid hormone acts on the GIT by means of vitamin D only. So, vitamin D increases calcium absorption from GIT. That is okay. It increases calcium reabsorption from DCT, okay, but it deposits the calcium in the bone. That is why beyond a particular age, everyone will be given calcium plus vitamin D supplementation. So when vitamin D is deficient, bones will be weak. Okay, remember, when PTH is high, bones will be weak. When vitamin D is low, bones will be weak. Calcitonin is another hormone which deposits calcium in the bone. Calcitonin comes as a drug also. So in conditions where bone density is low, we can give calcitonin. So why we came here? Because question is on hypercalcemia. Remember, even if you don't understand every basic of hypercalcemia, there are only two very, very important causes of hypercalcemia. Which hormone has to be high when calcium has to be high? High parathyroid. So hyperparathyroidism is the most important cause of hypercalcemia. And the second important cause of hypercalcemia is paraneoplastic, means tumors. So how all can tumors cause hypercalcemia? Some tumors like multiple myeloma erodes the bone. There are some cancers like prostate cancer. Prostate is actually osteosclerotic. We have some renal cell tumors, some lung cancers, etc., which deposit. When they metastasize in the bone, they cause light lesion. Actually, there was a mnemonic, LYTIC. L is lung, Y can be taken as U. So, ureteric tract tumors, testicular tumors, intestinal tumors, colonic tumors. All these are osteolytic, hence the mnemonic lytic. B for B, breast is osteoblastic. And what about prostate? Prostate is both osteoblastic as well as osteolytic. So some clinical clues may come. For example, a patient is having a cough with expectoration, there is clubbing, he is a chronic smoker, he presents with a lytic lung lesion and elevated calcium. So definitely some lung cancer is there. But again, lung cancer is not so easy because we have two types of lung cancers, right? Small cell lung cancer and non-small cell lung cancer. Among non-small cell lung cancer, we have squamous cell carcinoma, adenocarcinoma. Okay, at least remember these two. Remember, small cell carcinoma is a very important MCQ because most of the paraneoplastic, remember, most paraneoplastic manifestation. For example, if a history is given on Cushing syndrome, which tumor causes Cushing syndrome? Small cell carcinoma of the lung. Okay. So most of the paraneoplastic manifestations are due to small cell lung cancer except hypercalcemia, which is a paraneoplastic manifestation of squamous cell lung carcinoma. Okay. So which means this the case given is actually hypercalcemia. So if at all an extra clue comes that patient is having a possible lung cancer, the answer has to be squamous cell carcinoma. So how does squamous cell carcinoma cause hypercalcemia? I already told you, when parathyroid hormone is high, calcium will increase. The squamous cell carcinoma of the lung secretes a parathyroid hormone related peptide, PTHRP. It's not PTH, it is PTH related peptide, which causes the same hypercalcemia. Okay, don't get confused. I just wanted to say there are only two basic reasons of hypercalcemia. One is increased parathyroid hormone itself, that is called hyperparathyroidism. Next is paraneoplastic manifestation. Paraneoplastic can be due to some lung bone destroying tumors like multiple myeloma. It can be due to osteolytic secondaries, and for MCQ sake, remember squamous cell carcinoma of the lung, because it secretes parathyroid hormone related peptide which causes hypercalcemia. How does hyperparathyroidism occurs? PTH secreting adenomas or PTH secreting carcinomas or PTH hyperplasia. Even if you don't remember this one, just remember these two causes. Hyperparathyroidism and paraneoplastic are the two important causes of hypercalcemia. So coming back to the question. So patient is a young age female having high calcium level of 14. What is more likely to be the cause of the condition? So hypercalcemia, two causes: hyperparathyroidism due to either adenoma or carcinoma. Second cause is paraneoplastic. So whenever we see this question and think of the option, many of the people will go towards the second option, because many people will recite as squamous cell carcinoma of the lung causes hypercalcemia. But please remember, it's a young age female. They didn't give any other history regarding the lung. So read all the options before answering, right? Parathyroid adenoma causes hyperparathyroidism and it causes hypercalcemia. Okay, adenocarcinoma never causes, squamous cell never causes, of course, small cell cancer never causes. Squamous cell lung carcinoma is also an option, but think of the clinical scenario before you answer. Just a few add-on points. So what are the symptoms of hypercalcemia? You would have heard the groin moan pain disease. So it has generalized bone pain because of bone resorption. You would have heard the famous Brown's tumor in pathology. So there can be abdomen pain in hypercalcemia. Constipation can be there. In CNS there can be irritability. Okay. Suppose if question comes on treatment, the first treatment is hydration. So IV fluids are the main treatment, and we have to make calcium to get excreted. So we discussed in one of the videos, loop diuretics, furosemide or Bartter syndrome, both cause hypercalciuria. So that is one treatment. Then I already told you about calcitonin is a hormone which deposits calcium in the bone. So we can give calcitonin. We can give bisphosphonates. They are drugs which deposit calcium in the bone. So we have many bisphosphonates like zoledronic acid, alendronate, pamidronate, ibadronate, etc. Okay. So in endocrinology, few topics are important, like cortisol is very important. We discussed in one of our previous videos about Addison's, Cushing's and all. So hypercalcemia is also very important. So whenever you have to remember something about hypercalcemia, think of the three important hormones: vitamin D, PTH, at least remember PTH, calcitonin, and important causes of hypercalcemia being hyperparathyroidism, and second cause is malignancy. Of course, there are few other causes. For example, excess vitamin D can cause hypercalcemia, hypervitaminosis D, like toxic doses of vitamin D. There are some conditions like sarcoidosis which secrete vitamin D, but they are rare causes. So at least remember the first two causes. So coming to question 31 of previous year NEET questions. So a 43 years old male comes to you for pre-op evaluation for hernia surgery. You finding to be HBsAg ELISA positive. You go on to evaluate this patient and find that his HBC, anti-HBC IgG is positive and anti-HBC IgM is negative. HBeAg is negative. What is the interpretation? Of course, many of us have the tendency to leave off this question because it is somewhat confusing. Okay, many people have many different approaches to teach the serology of HBsAg, hepatitis B. So I'll try my best to make you understand my approach. So whenever a question on hepatitis B comes, always remember three antigens. Okay. Remember see the caps and small letters also. Hepatitis B, SAG. So see the caps and small. We have HBCAG. HBeAg. So capital H, capital B is hepatitis B. The small s is surface, Ag is antigen. Hepatitis B surface antigen. Also called Australian antigen. HBCAg is hepatitis B core antigen. Core is it is present within the structure of the hepatitis B virus. HBe is E antigen. Okay. Envelope antigen. Remember, since core is within, core antigen does not come out. So in clinical context, we don't measure HBCAg. So these are the three antigens which are measured. Two antigens are only clinically important. So HBsAg and HBeAg. Okay. When antigen is there, antibody also will be there, right? So when HBs antigen is present, there will be anti-HBs antibody. When there is HBCAg, there will be anti-HBC antibody. When there is HBeAg, there will be anti-HBe. Again, for clinical relevance, anti-HBe is not important. Remember, in antibody, we have 5 types of antibody: IgG, IgA, IgM, IgE, and IgD. The mnemonic gamed GAMED. Always we have to remember IgM is the acute antigen. Whenever an acute infection is there, acute antibody, IgM is the acute antibody. The first one to start is IgM. It's a pentamer. IgG is the chronic antibody. Whenever some infection is chronic, IgM gets converted to IgG by class switching. IgA, remember one thing, it is secretory antibody. Like it is the one which is secreted by the GIT and it helps in the defense of the lining immunity, lining cells of the GIT. We have IgE. IgE is very important in allergic conditions. We are discussing it in neutrophils. Remember, interleukin 4 stimulates IgE secretion. And IgD, it's not very important. So M and G are very, very important because IgM is the acute antibody, IgG is the chronic antibody. So in anti-HBC antibody, we have two. Anti-HBC IgM antibody, anti-HBC IgG antibody. Sometimes these are measured together called as anti-HBC total antibody. Okay, so 3 antigens, 3 antibodies. So taking again the clinically relevant parameters, we have HBsAg, which is the surface antigen, HBeAg, which is the envelope antigen. I told you HBcAg, core antigen, is not seen in blood. So 2 antigens. Regarding antibody, HBsAg is usually measured as total, a single one. There is no clinical relevance of anti-HBs is usually taken as a single entity. We don't usually differentiate between HBs, IgM and IgG, but anti-HBC, we take it as IgM, and anti-HBC IgG. We'll keep it like this for ease of purpose, but usually what is measured is IgM is measured, total is measured. The difference will give you the IgG level. Like if total is elevated, IgM is absent, the entire thing will be IgG. If total is elevated, IgM is elevated, obviously IgM and IgG both are there. Okay. Now what does these things indicate? If HBsAg is present in the blood, it definitely means the virus is there. So presence of HBsAg denotes infection, right? We'll write it in a different color. Presence of HBsAg indicates infection. What does HBeAg indicate? So EAG always denotes active replication. So whenever HBeAg is present, it means active replication. The disease is active. Now, what does anti-HBs indicate? HBsAg denotes there is an infection. Anti-HBs denotes there is an immunity to infection. So in which condition anti-HBs will be elevated? A prior infection or an immunization. So if HBsAg is positive, anti-HBs is positive, patient has an infection definitely. So there's an antigen and there's an antibody for that. Suppose if HBsAg is negative but anti-HBs is positive, what does it denote? It indicates patient was vaccinated. So he does not have the infection, but he has the antibody. So patient is vaccinated. Right? I'm not bringing this one to this main tabular column, but this can also come as a question. Now, anti-HBC IgM. So what does anti-HBC IgM indicate? Something is acute. So there is an acute infection. What does anti-HBC IgG indicate? Whenever IgG is there, it denotes chronic infection. Alright? So if you understand the core concept of IgM and IgG, things are very easy. So if HBsAg is present, it denotes infection. If HBeAg is present, it is replication. If anti-HBs is present, it may be either infection or immunity. If anti-HBC IgM is present, it denotes acute infection. If anti-HBC IgG is present, it is chronic infection. We can take many different combinations. For example, HBsAg is present. HBeAg is present. Anti-HBC IgM is present. What does it indicate? When HBsAg is present, what does it denote? There is an infection with hepatitis B. When HBeAg is present, what does it indicate? There is an active infection. There is replication of the hepatitis B virus going on. What does anti-HBC IgM indicate? Means something is acute. So there is an acute HBsAg infection which is actively replicating. Right? Let us take another example. HBsAg is present. Anti-HBC IgG alone is present. And HBeAg is absent. Okay. Now how will you interpret this serology? When HBsAg is present, what does it indicate? There is a hepatitis B infection, definitely. HBeAg is absent. So, is it an active infection? No. So, infection is inactive. We can say it as latent also. So, there is no active replication, but infection is there. HBC IgG. What I told you, IgG means it's a chronic infection. So, it's a chronic latent hepatitis B infection, which means patient was infected with hepatitis B. So, patient has a chronic HBC IgG antibody present, but there is no replication going on. But can this get activated? In some conditions, this inactive infection may start replicating again. In that case, HBeAg will become positive and patient will develop symptomatic again. How does he become symptomatic? He will develop jaundice. He will develop a rise in liver enzymes of ALT and AST, and he may become sick. Right? So, this is my version. Right? Just try to understand what does HBsAg mean, what does HBeAg mean, what does anti-HBs mean, what does anti-HBC IgM mean, what does anti-HBC IgG means. Don't confuse capital H, capital B, small e, small capital A, small g with capital H, capital E, capital B. This is hepatitis C, right? HAV is hepatitis A virus. HEV is hepatitis E virus. HBeAg is hepatitis B envelope antigen, E antigen. Many people get confused, that's why I mentioned it here. So we'll erase off all the other unnecessary things and we'll just discuss about this question. We'll try to solve it together. So we are taking this question together. Just remember this meaning. So 43 years old male comes to you for pre-op evaluation for hernia surgery, which means symptom wise he is asymptomatic. He just comes for a routine pre-op evaluation. On routine evaluation, you find him to be HBsAg ELISA positive. So hepatitis B surface antigen is positive. They have mentioned ELISA because usually we do CART test initially. When that screening is positive, we confirm it with ELISA. That's why the word ELISA is given. Don't get confused. So hepatitis B S antigen is positive means there is an infection. So he was infected with hepatitis B sometime. So you go on to evaluate this patient and find that his anti-HBC IgG is positive and anti-HBC IgM is negative. So this can be given in other terms also, like total anti-HBC is elevated, but anti-HBC IgM is negative. Like that also they can give. But for ease of understanding, I have given as anti-HBC IgG is positive, IgM is negative. So when IgG is positive, what does it mean? It is a chronic infection. So a patient is having a chronic hepatitis B infection. Anti-HBC IgM is negative. So there is no acute infection. Now hepatitis B, E antigen, envelope antigen is negative. What does E antigen indicate? Active replication. When EAG is negative, what does it mean? The disease is inactive. It's not actively replicating. So it is chronic inactive hepatitis B. Okay. So we'll see the options. Is it acute hepatitis B? So what will be the serology in acute hepatitis B? HB, SAG will be positive, right? Acute. So anti HBC IgM will be positive. What will happen to the HBEAG? It will also be positive because in acute hepatitis, active replication will be going on. What happens in resolved acute hepatitis B? So it is also an infection, so HBsAg will be positive. In late stages, it may become negative also because not all cases of acute hepatitis B will progress. Sometimes the all viral load will get cleared, but for our sake, we'll take it as HBsAg positive. What will happen to the antigens? Anti-HBC will be negative. Sometimes anti-HBC IgG alone will persist because once resolution of IgM occurs, it will get converted to anti-HBC. So anti-HBC IgG will become negative. There is no active replication, so HBe antigen will be negative, right? But practically, HBsAg also will be negative because once resolution occurs, infection will not be there. So what is the telltale sign of infection? Only anti-HBC IgG will be negative. Okay, so as time goes on with resolution of acute hepatitis, HBsAg will become negative, anti-HBC IgG alone will be positive, HBeAg will be negative. What happens in chronic hepatitis B? HBsAg will be positive, right? Because infection is there. Since it is chronic, anti-HBC IgG will be positive. They didn't give any word whether it is active or inactive. So I think for this term, only these two will be enough to say. To say chronic active hepatitis B, in addition to these two things, HBeAg will be positive. So I think for this question, chronic hepatitis B will be the answer because HBsAg is positive, his anti-HBC IgG is positive, but there is no replication. So he is having a chronic hepatitis B. Will you treat him or not? So maybe beyond the scope of NEET PG, unless they are symptomatic, unless their SGOT, SGPT levels rise, unless they have jaundice, or there is a family history of hepatocellular carcinoma, you need not treat. Okay, you need not treat every case of HBsAg. Maybe this can come as a question like patient was exposed to a blood having hepatitis B virus. So like a healthcare professional gets a needle prick from a person who is HBsAg positive, then what will you do? So if you get pricked with the hepatitis B infected blood, so what you have to do immediately is you have to check HBs, anti-HBs, because that is the one which indicates your immunity. So if you are HBsAg negative, but your anti-HBs titer is good, usually they say more than 10 units per liter. If your HBs titer is good, you are not having the virus in your body, then there is no need to vaccinate because you are already having adequate immunity, so you will not get the infection. Suppose your HBs titer is low, you are not previously vaccinated, means you are having the chance of getting infected. Even if you are vaccinated, always it is good to check your HBs levels after a prick because sometimes HBs levels, anti-HBs levels may come down with waning immunity. So just because you are vaccinated with hepatitis B doesn't mean that you have adequate immunity. So always, even though you are vaccinated, if you get a prick with the hepatitis B serum, do anti-HBs levels. If it is high, that's all. You know, no need to do any special thing. If anti-HBs is low, you must take the anti-hepatitis B serum. After this, you have to get your booster dose of hepatitis B. Now, since we came about blood prick for HIV is important. So here they'll be giving the exposure categories and source category. Exposures, whether it is just a superficial exposure or a deep exposure, like that, they are giving exposure category codes. Source category, whether the patient is known HIV positive or the source is unknown. Like, we have to take prophylaxis only when the exposure is severe or deep or a mucocutaneous exposure and the source is a definite positive. Okay. What about hepatitis C? For HIV, if you read your textbooks, they will be giving EC1, EC2, etc. I just want to tell, to give a prophylaxis, the exposure has to be severe, source has to be clear. Hepatitis C, remember, there is no prophylaxis. But hepatitis B is the only treatable hepatitis. Treatable and curable hepatitis. So if you get a prick with hepatitis C serum, there is no prophylaxis. You have to get infected with hepatitis C and you have to take treatment and get cured, right? Okay. So the actual NEET question was, they are given about resolved hepatitis B. HBsAg was negative, only HBC, anti-HBC IgG was positive. And HBAg was negative. So that was the actual question. So I just, to make you understand, I framed a different question. So coming to the last question of NEET PG 2024 recall. So this is a big question. We'll read the last line. What would be the ideal next step evaluation? So some disease has to be diagnosed and we have to tell what is the next step. A 50 years male patient comes with generalized body pain and low back pain. He was advised complete evaluation. His report showed the following abnormal findings. So we will note down. HB was 7 gram per deciliter, so there is anemia. Creatinine was 3.1, so there is renal failure. ESR was 130 mm in 1 hour, so a very high elevated ESR. Calcium was 13. So again, hypercalcemia. The normal calcium level is 9 to 13 milligrams per deciliter. So 9 to 11 milligrams per deciliter. 13 is definitely hypercalcemia. There are multiple lytic bone lesions in his spine X-ray. So there are some bone lesions. I think the clue becomes very clear here. This is crab, right? Hypercalcemia, renal failure, anemia, and bone lytic lesions. So whenever crab clue is given, the answer definitely becomes multiple myeloma or myeloma. Some people get confused about the term monoclonal gammopathy, etc. So I'll just tell you. I told you in another video about T cells and B cells. B cells mediate humoral immunity. So how does B cells go about? When B cells are stimulated by interleukins like interleukin 4 or 5 particularly, they get converted to the plasma cells and they secrete the immunoglobulins, gamed IgM or G or A or E or D, based on a particular interleukin, based on the particular type of plasma cell which gets formed. Now we know the immunoglobulin has heavy chain and they have light chain. 2 heavy chain and 2 light chain. The light chain can come in 2 varieties. Kappa light chain or lambda light chain, right? So these are the 3 proteins which are secreted by the plasma cells. They are secreted as an immunoglobulin, but to be separate, they can be they produce separately as heavy chain, kappa light chain and gamma light chain. So they come in different combinations. Okay, in few kappa light chains will be produced and few lambda light chains will be produced. So everything comes together. Remember, when everything is mixed together, we call it as polyclonal. Okay. For example, assume some conditions where B cells are more, plasma cells are more, and immunoglobulins are more. Remember, I told you about rheumatoid arthritis. It is a disease mediated by humoral immunity. Psoriasis is a disease mediated by cell-mediated immunity. So in rheumatoid arthritis, what happens? There are more B cells, so they produce more of plasma cells and more of immunoglobulins are produced. So that excess production of immunoglobulin is actually a polyclonal production because different heavy chains, different light chains are produced. Both kappa and lambda light chains are produced. So even though there is increased immunoglobulin, it is actually a polyclonal excess of immunoglobulin. So polyclonal rise. Whenever the term monoclonal, like only one particular cell type of cell is produced, it is always cancer. It is always malignancy. So assume a disease where different types of chains are not produced. The B cell becomes neoplastic. It produces a particular neoplastic plasma cell. That neoplastic plasma cell secretes only one type of cell. Either it produces heavy chain alone in excess, or it produces only kappa chain in excess, or it produces only lambda chain in excess. Then it becomes problematic. When heavy chain is produced more, we call it as heavy chain disease. It's not important for your NEET PG, but there's a disease called heavy chain disease. When either kappa chain or lambda chain is produced more, so that is named as monoclonal gammopathy. This also can be given the term plasmacytopathy because plasma cell is becoming abnormal. So whenever the term comes plasmacytopathy or monoclonal gammopathy, it always means a disease related to multiple myeloma. So now this monoclonal, so we'll discuss this. So clearly it's a case of multiple myeloma. What is the ideal next step in evaluation? Serum vitamin D levels. Okay, maybe an ideal evaluation because we told you when calcium is high, what are the two most important causes? Hyperparathyroidism and malignancy. So to evaluate for that, we can send PTH levels. And I told you the third cause, vitamin D toxicity also is there. So we can send vitamin D. And we can send PTH related peptide, or we can check for the screening, the lytic, right? The lytic cancers. We have to look for lung cancer. We have to look for urethral tract cancers. We have to look for intestinal cancers, colonic cancers. So look for every cancer. Okay. So this also is seems to be a good option. But what is the best? They have asked the ideal next step. Because serum vitamin D level does not explain the low hemoglobin, the high creatinine. Okay. And ESR more than 100 always occurs in only few conditions, like it occurs in rheumatic fever, rheumatoid arthritis, multiple myeloma, and tuberculosis. So see, these are the conditions where usually you can tell lymphoma also. These are the conditions where ESR is very much elevated, more than 100. So ESR more than 130 does not explain hypervitaminosis D. Serum ionized calcium. So why the term serum ionized calcium? Ionized calcium has to be sent for a confirmation of hypocalcemia, not hypercalcemia. Remember, whenever calcium is low, it does not mean actually calcium is low in the blood, because some of the calcium is bound to albumin and some of the calcium is the free ionized calcium in the blood. What is the calcium measured in the serum is actually calcium bound to albumin plus the ionized calcium. But what is more important physiologically is only the ionized calcium. So the calcium which we measure is actually a surrogate of the physiologically important ionized calcium, which means calcium can be falsely low, that is measured calcium can be falsely low when albumin is low. So assume conditions like hypoalbuminemia, like in chronic liver disease, we can get falsely low calcium. In that case, we have to send ionized calcium to confirm whether the actual physiologically active form of calcium is normal or low, right? So ionized calcium has to be sent as a confirmation in hypocalcemia. There is a formula for corrected calcium, we are not discussing it here. Next is serum protein electrophoresis. So this is the investigation of choice in multiple myeloma. So that is the next step, serum protein electrophoresis. Serum CEA is a neoplastic marker, or it's a marker of colonic cancer. Of course, colonic cancer with meds also could be the answer, but it does not explain the renal failure, high ESR, etc. And nothing is given about the clinical scenario. Like there's no bloody diarrhea given or no bowel disturbances given. So this is less likely. So maybe a challenging question. From this question, serum protein electrophoresis is more likely. So many of us will get confused about the serum electrophoresis. Remember this one. Okay, the upright palm is out. So if you draw a graph about protein, initial spike is albumin. Okay, then we have two spikes, alpha 1 globulin, alpha 2 globulin, and beta globulin. The last gamma globulin will be little smaller than the albumin. That is how the normal one should be. Suppose if this last one is very high, spiking even more than albumin, it is significant. It means albumin is low or globulin is high. Remember, immunoglobulin is also a type of globulin. Immunoglobulin has kappa chain, lambda chain, and heavy chain. So in monoclonal gammopathy, when kappa chain or lambda chain increases, globulin has to increase. So when it is a monoclonal rise, it will rise very much like a peak. So this peak is called as M protein or M peak. M is for monoclonal peak, right? So this is actually how does it look. So this is the chromatography or serum protein electrophoresis. See, in all these pictures you can see the initial spike is very, very big. So this is the actual albumin. So the next one will be alpha 1, alpha 2, and the last one will be the gamma protein. See this image number 3. Albumin peak is more, but we are having another peak at the level of gamma, right? Which means the last one at the thumb level. So this is how does the electrophoresis of myeloma look. So the same image can be given like in a horizontal orientation, but whatever it is, don't forget this palm image. The first peak is A, albumin. Next comes globulins, alpha 1, alpha 2, beta globulins. The last one is gamma globulin. When it is very high, it is called as M peak. Of course, we are having many other investigations in myeloma. For example, previously they did the Benz-Jones proteins. It is outdated now, so don't answer this one. So which is the best screening test is serum protein electrophoresis. Serum protein electrophoresis will only tell that there is a monoclonal gammopathy. But to plan treatment, we should also find out which light chain is elevated. So there is something called SFLC, serum free light chain assay. Like it tells whether kappa chain or lambda chain is elevated. Then people also do biopsy. Okay, so these are the investigations. So remember myeloma because it produces crab. And if you have to go to the next step, like this plasma cytopathies are of multiple types. So few terms are MGUS, monoclonal gammopathy of uncertain significance. We have something called as smoldering myeloma. And last is multiple myeloma. So what is this monoclonal gammopathy of uncertain significance? The M protein level is less than 3 gram percent and the plasma cell count is less than 10%. So monoclonal, even though it is elevated, it is less than the cutoff because M proteins more than 3 gram percent and plasma cells more than 10% only is the criteria to say it is multiple myeloma or smoldering myeloma. Here it is below the cutoff. So even though there is monoclonal gammopathy, it doesn't fit the cutoff. So it's called MGUS, monoclonal gammopathy of uncertain significance. Smoldering myeloma is like a precancerous condition. That is, there is elevated M protein, there is elevated plasma cell count, but there are no symptoms. So if the same question or if the same electrophoresis pattern is given, but the scenario doesn't give any symptom, then the answer has to be smoldering myeloma. Multiple myeloma, the same criteria. M protein has to be more than 3 gram percent, plasma cells has to be more than 10%, plus there has to be crab, one of the crab. Crab is hypercalcemia, renal failure, anemia, and bone changes. Okay. So we took some time here to discuss about multiple myeloma, its pathogenesis, its types, okay, and serum electrophoresis interpretation.